Hey everybody, this is Erica Mello and welcome to episode number 53 of Tough to Treat. And this episode is about a patient of mine who I was currently treating at the time of the recording, who came to see me with the belief that his issue, his hip pain, was caused by an overactive TFL. Clearly he had an overactive TFL, by looking at him, but was that the cause of his problem, or was it a compensatory issue? And Susan and I clinically reasoned through this patient's issues, and he had a problem sitting. So when I focus on patients who have issues sitting, I look at their squat, I look at them actually sit. But he also told me that he could not squat with a barbell on his back. So this whole podcast really focuses on clinically reasoning through the patient's past medical history, and is it contributing to his symptoms now? And it generally is. With these patients who have persistent issues, their past medical history is so important, and they don't believe it to be so until you actually point it out to them. So without further ado, we hope you enjoyed the podcast, and thank you again for listening. Enjoy. Hi, everybody. This is Erica Mello and Susan Clinton. Welcome to Tough to Treat. How are you, Susan?
I'm good. How are you, Erica?
I am good. I forgot what episode we're on now. This is maybe 53, I think. 53?
Yeah, I think we're on 53. So,
oh my gosh. Wow, it's crazy. I'm going to get right to it because this is a gentleman I am treating now. A lot of them I talk about I'm still treating, but this is like rather newish, so I've only seen him twice. So he is 38 years old. He basically, came in to see me, hadn't really seen anybody before, had been to a pain management doctor who I can explain in the history, but he hadn't had any physio. So he came in complaining of left lateral hip pain and butt pain on the same side. Also, some right low back tightness. And he kept saying to me, my TFL is overactive on my left side. He's very well. He was, he's works on Wall Street here, educated, did a lot of reading up on his issues. And my TFL is too much. It's overactive. He sees a massage therapist who does his thing, and he's quite good apparently. And he feels a lot better after, but then it comes back. Not surprising. So his main issues were, because he sits on a trading floor, his main issue was sitting and a squat with a barbell. So when he squats normally, he doesn't usually squat without weight. So he'll put a barbell on his back, and then he'll get a lot of the left hip pain. The right low back wasn't like the main issue. It was mostly the left hip, but he happened to mention that because he feels that occasionally. So squat and then sitting, he told me he was getting a sit to stand desk at work in the history. So they did an MRI of his low back, and I don't have a copy of it, but he said it didn't really show much. Not surprising. I mean, he's 38. He was going to get an MRI of his hip, which I don't think was necessary, but this pain management doctor wanted him to have it. So his history is in 2012, he slipped and fell in the gym. Okay. He basically, quote unquote, said he had a tear in his disc. I had to rectify that immediately, but he slipped and fell, and he had on and off butt pain and back issues for years, but he managed. And then he said that he felt that he had his glute tendon was torn, but nothing ever was shown. This is just probably from reading on the internet. He also had a right ankle injury, and that was probably after 2012, so probably about 2014, where he kicked a wall. Like he just basically put his foot and kicked a wall. And he didn't get any physical therapy for that. He just kind of walked around as is, and it just resolved on its own. And he had a left shoulder problem, but that was not really, that was an on and off issue. He never really had physical therapy for any of this stuff, I think. I mean, a little bit, but it was many, many years ago. He actually lived in London for 6 years, so he had some physio there. And when he went to see the pain management guy, he basically was going to give him an EMG. And so they started up with the EMG. I would say within 5 minutes, it was so painful. My patient said, "Stop, I'm out of here," and left. So the past 4 months, he's been pretty flared up with the left hip. And he's been doing a lot of these high intensity workouts. Like, I don't know if you've ever heard of this. He called it C something, a metabolic workout, like a complete metabolic workout. Have you heard of that, Susan? Like I forgot what it was called. Oh, Metcon, metabolic conditioning.
Is that the one where you ride the bike as hard as you can for 20 seconds, 3 times 20, and repeat for 3 to 5 sets or something?
Probably.
Where it really fills your legs up. It's supposed to be like for people that it's a different kind of a workout, and it does target the metabolic conditioning part, which is why it's called Metcon. But I only know a little bit about it. It's on my list of things to really pay attention to.
Yep. Interesting. I don't know much about it at all. But he started doing that. And when he lived in London, he ran about 50 to 60 miles a week, just FYI. And he's a former swimmer, and in college, and he pretty much ran quite a bit. He has a daughter, probably about 2, carries her on his left side.
Okay.
Often. And so basically, with regards to sleeping positions, when he lies on his back, he said it bothers him. When he goes on his tummy, his back bothers him. But his best position is lying on that left side. So that's the position he actually sleeps in. So in the morning versus the evening, he was stiff in the morning, but that's nothing unusual. So his main issue was sitting and squatting with weight. Walking was fine. Standing was fine. I'm just looking if there's any other medical issues that he has. When he's sitting on the trading floor, he basically sits on, like, leans to the left, like off his right butt cheek, and leans to that left side because the screen he needs is on the left side, according to him. So this pain management guy gave him some exercises to do, he said, which helped. And I'll just tell you what they were. They were side planks bilaterally, front planks with alternating leg, Supermans, and hip bridges. That's what he said. He said he felt okay with that.
Yeah, that would make sense.
Yeah. So that's his history. Do you have any questions before I move on?
The sitting on his left side, because the way he has to look at the screen on the trading floor, I imagine that's hours a day.
Yep.
And does he sit high or low, or does it, is he on a stool? I don't know how trading floors work.
Oh, yeah, he sits on it's a regular chair.
Okay, so he's not up running around like the people who you see on TV.
No. So he did what I used to do. So basically, you've got a few screens in front of you, generally 2 to 3, and the one that you use the most is the one you focus on. And his was to the left. We've since changed that, but his was to the left. So he didn't realize that until I brought it up. But yeah, you're sitting in a normal chair, no headset,
and that is changeable where your screens are.
Correct.
Okay.
Correct.
All right.
Correct.
And he has this thing in his head about TFLs.
Yes, big time.
Okay. Yeah. So it sounds like to me that we are messing with some sort of very sensitized system somewhere in his lumbar. This is my guess, somewhere in his lumbar spine that is firing off that left lateral hip pain. I don't think it has anything to do with the TFL. Not sure I buy the whole TFL issue, but there is over recruitment of the muscles probably.
Oh yeah.
And if he carries his daughter on the left side, he's jutting his hip out to the left, which is why it's more comfortable to sleep on his left side because it pulls his pelvis the other way.
Correct.
And gets his back out of whatever that right side bending and rotation that's going on with his left hip stuck out. Didn't you say he had right low back pain at some point?
Yes.
Yeah. So, so something's kind of gone off a little bit there. I'm interested to see what you did, because I certainly would be looking at, me bend overs and squats, but I would also be looking at load transfer with him. Like, how's he coping with standing on one leg and the other leg?
Yes.
Yeah. So here we go.
Right. So what I did, I just took a look at him in standing, and when I tell you his quads, I was like, the guy's not even a cyclist. Okay. His lateral quads were crazy. I mean, so much dominance there, and more on the left, obviously. I mean, it was like the guy worked his quads 24/7. I mean, it was crazy. So he was way over on his left side, and I could not. I was like, you're standing on your left leg, and my guess is he offloaded that right foot injury.
Yeah, really, that was the right ankle, right?
Correct.
I thought about that when you told me about that. I thought, oh, we've moved way over on the left side to get off that right ankle.
Right. And he never had it treated. So it was probably just, I'll just get better on my own type thing. And he's super flexible. He's a swimmer. He's not one of these stiff, so basically in standing.
So I have to throw this out here before you go further into your thing. It's very interesting, some of these ankle injuries, and when, the people can get where the pain goes away and they can cope with it pretty well, and they can stand and walk on it pretty well. But in speaking with Scott Epsley, who is PT for whatever the basketball team is in DC, I should know, but I can't ever think of the names of teams. But anyway, he was talking about rehabbing some of their injuries, these very movable, tall, lanky athletes, and watching them move, and with all their movements that they have to do with their arm up in the air to grab the basketball and coming off of their feet. And he was talking about having to actually kind of go all the way back and reintegrate some reflexive patterns, because as soon as he starts to maybe move in a certain way reflexively, he doesn't have the piece there and may be over relying on that left side. Anyway, my 2 cents. I just thought it was interesting.
Yeah,
since we've got this ankle foot thing going on clear on the other side, very distally, wondering how that's driving the neurological system and its ability to kind of like try to find where it is in space, and how to cope with a child on the hip and sit all those hours sitting and just doing the various things. So okay.
Right. It's the same movement. That's very fascinating. It's the same movement pattern over and over again. And I think sometimes when you offload a foot, and because I see this a lot, is that it affects your gait. You can't get that, if you don't have any dorsiflexion in that right foot, you just can't get the hip extension in gait. You just can't move as well. So I always if I see a significant shift like that, if they haven't told me about an opposite foot injury, I ask. Because I think that is relevant, especially when it comes to feet. So in standing, I shifted to the left. His feet were extremely rigid. You've got these supinated, high arch, rigid feet bilaterally. And so he had like this left tilt. So I put my hands on him because he was so on his left side. It looked like he was in this sort of right side bend. His iliac crest was, and I don't go a ton by bony landmarks, but he was so hiked up on his left side. Iliac crest was a PSI, as a, they were all up, all hiked up. And in addition to the vastus lateralis dominance, TFL on the left side versus the right. That's what I saw in standing. I put my hands on the front of his hips just to see if there was any asymmetry. He had a little bit of fullness in the right hip, causing a little bit of a pelvic rotation to the left side. Not surprising. And I look at his upper thorax. His upper thorax was shifted to the left. The only thing that was right was his head. Which makes sense. He's sitting he's sitting on the trading floor in this sort of left right, sort of slouch position. He's got to turn his head to such right at some point, or he's going to fall over. So what I did is I had him bend forward. I said, let me see how you move. Okay. I had him bend forward, and then I was like, he looks fantastic. I was shocked. His I call it a TPR, his pelvic rotation corrected, his hips seated. He had no problems. He went right to the floor. He did his foot dorsiflex, not really, but he had no major problems. And I was kind of surprised. The only thing that I saw in a forward bend was when he bent over, and this was at the end, his upper thorax shifted to the left,
mm-hmm.
which could be relevant, could not be. But other than that, I saw nothing. And then I had him squat. I didn't do any back bending or anything like that. I didn't think that was going to get me anywhere, so I could have, but I didn't. So since his main issue was the sitting, I said, just squat for me. And I had him squat. Once again, the pelvic rotation corrected, his hips corrected, his upper thorax still was shifting. So something still was shifting. His right foot was not. So when you squat, I had him squat low because I wanted to see if his right foot dorsiflexed, if he was able to get the talus posterior, if he was shifting his weight off of to the left because of that right foot. His foot was still a bit rigid, to be honest. And so was he shifting his upper body to offload the right foot? I don't know. So what I did was, I'll tell you in a second, I wanted to see him squat on a squat rack with the bar, because that was his issue. So I took him out to the gym, put him on the squat rack. When I tell you, the minute he put the bar on his shoulders, his entire body shifted to the left, and it was glaring. He took it off the rack, put it on his shoulders, and the entire body shifted. Everything, the rotation, his whole body just shifted. So I'm going to stop there, and I would like your thoughts on that.
Yeah. We keep talking about this whole offloading of the foot, and I just want everyone to understand that it doesn't have to be a pain issue at all. And it may have been in the very beginning, because, you kick a wall, it's going to hurt. I mean, pain's protective. It's supposed to be there. But we're talking about that was 2013, 14?
Yeah, 13, 14, yeah.
Some time ago. And, the issue is that I think it kind of gets into that stuff that we're not really great at measuring yet, but it's like that whole proprioceptive piece. So perhaps there was some proprioceptive input loss or change because of the way the brain's going to protect the foot and ankle after kicking a wall. And so that when you start to load that up, if the system senses that the stability occurs on the left side, if you start to load that, you're going to, I would dare to say that was probably a great move, because it was going to really show you where his system wanted to be under loading.
Yeah.
And so, he puts his kid on that side, he feels more stable over there. Some people say, oh, they do that because then they're right-handed, they could write. It's like, no, I have too many ladies who put their kids on their right side and they can't write with their left hand. It's just kind of one of those diagonal dominances that we have. We can all put our hands together, and you can lace your fingers together in front of you, and you have a certain way that you do it. There's one thumb is going to be on top all the time because that's your dominant diagonal pattern. You can do it the other way, but you don't want to.
Yeah.
Your whole brain, everything in you says, no, go back to the other way. It's where we want to be. And so his system is doing that too. It's been trained to be over there for whatever reason.
Yeah.
And but that's fascinating that it's the second he loaded, he really exaggerated that shift again.
Yeah.
So and I think that there may be something that the brain's gotten used to the lack of input from the right side, or maybe the input that's coming through doesn't match up to the left side, so it's only hearing the noisy side. We can debate that till the cows come home, but the idea is that that's where his system feels stable, or he wouldn't be loading that.
Right.
Even if it's not true, that's what his system has perceived. Yeah.
Correct. Yeah, it's a great point. And, it's funny because in the squat, and I'm just going to go back to the hip rotations, because in standing, his pelvis was rotated to the left and his right hip was forward. That makes sense, right? When he squatted with the bar, it went the other way. His left hip went forward. His whole pelvis shifted, body weight shifted to the left hip went forward, and his pelvis rotated to the right. Normal. I agree with you. His body was seeking stability. And that's how he got it. And I mean, I was like, I mean, he didn't even have to squat. He just put the bar, he put the weight on his shoulders, and it was like, boom. And he's a smart guy. So I said, I need you, this is what you're doing. I need you to correct this. And that's all I said. And he went, oh. And he tried. And it was very hard because the body knows what it knows, right? So that was for me. And I know a lot of people don't have access to a squat rack, okay? However, if you have weights in your clinic or have them hold something, you can try and see if their strategy changes under load. Because I was expecting to see something in the squat besides the upper thorax, okay? However, I didn't. And when he actually put the load on the shoulder, on his arms, everything changed and reversed. So that was, the opposite end of the spectrum. So I came back and I sat him on the table and I said, let me just check your hip flexion, because he doesn't have a ton. He had like 90 degrees bilaterally, enough. Not enough for a deep squat unless he does a really wide base. So I had him, I'm actually going to backtrack. I had him do narrow and wide base. And obviously the wide base was significantly better. It leveled everything out. It was much better. So I also checked his thoracic rotation in sitting. To the right, he was pretty good. To the left, he was significantly limited. And when I mentioned that, he's like, oh, when I play golf, they tell me I have this really great backswing. I'm like, well, you have a lot of rotation. You're shifting to your right leg, interestingly, when you're on that backswing. But when you're coming through and you're going onto that right leg, which you can do, he's limited in his thorax, so he doesn't have the left rotation.
Right, because he's rotating all the time.
Right, so he's trying to muscle through on his left side because he has to hit the ball. So that's how I explained it to him. I don't know if you have any thoughts on that. I'll stop. But because it was significantly limited versus the right.
I thought what's interesting here with the golf swing is now we're bringing rotation into the system.
Right.
And he can rotate on the side where he's not hanging out all the time.
Right.
Because he's hanging out on the left all the time, but he has rotation to the right. We know he does because he's staying out on the left all the time. So right rotation in that trunk makes a lot of sense. It's interesting that he'll put his foot down, but you're also calling on a different movement pattern.
Right.
Than just standing and loading.
Yep.
So because you're bringing rotation into the system, you're seeing different things now. And that just shows you that he has the ability and the availability. It may just be a movement pattern, motor control pattern that's just gotten in there and has become that mass pattern of movement on the left side. And I love the fact that rotation actually took it away a little bit.
Yep.
Of course, as he came through with trying to rotate to the other side, he wasn't so great at it. But it just demonstrates that, when you put rotation in, you can start to see all kinds of things go on. And that can actually change some of those patterns a little bit. I'm finding it very interesting to kind of think about what can he do with that squat bar to bring some rotation in that might help change what he's doing with squatting. So this is great.
So I will go back to that. So his hip flexion was 90 degrees bilaterally. He has tight hips, the thoracic limited to the left. I just checked his right foot. No surprise, dorsiflexion was significantly limited on that right side. He's like, should I have my massage therapist work on it? I'm like, yeah. I went in, I poked around the calf a little bit. He had some fascicles that were quite tight. I'm like, yeah, I can do that. But if you're going to see this guy regularly, that's fine. You can just have him do that because you need some input to the foot. And I'm happy for him to work on that. And I can work as well. But I didn't check. Did I have him go in his tummy and did I do a lumbar? So I went in because he had this right low back issue. I did his accessory mobility. It was normal. He had, his right iliocostalis longissimus on his right side had a little bit of hypertonicity around the T8, T12 segments, but nothing abnormal, to be honest, in his lumbar spine. His main issue was this sense of TFL, this dominance on this left side. So because he wanted to, his goal, I said, what do you want to be able to do right now? besides get rid of this issue? He's like, I want to be able to go in the gym in the morning and do something. I was like, okay. So I basically, he's the kind of guy, he's like, can I do lunges? Can I do this? So what I gave him, I said, just you need to stretch your calf at the very least, you know, in your hips. Go on the half foam roller, stretch the calf, and do your hip stretches and your basic ones. And then I had him do some side stepping with a band to the right. I just said, you need to get off your left leg. Just do side step with the band around your ankles or just below your knees to the right. Just go to the right, 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 right. Just do not go to the left. That's what I told him. And then I actually had him lie on his, like go into, on his right side, and I had him do some, like I call them book covers. So you're lying on the right side in a fetal position, and you're just opening up your thorax, like you're just trying to get more rotation to the left. So I had him do those, and then I had him, I said, take the band off. I want you to stand up, wider base of support. I want you to feel both feet on the ground. I said, I need you to tune into where your weight bearing is. I need you to get your weight equalized. And I wanted to see if he could do it. And he could. So I said, that's a good self-check for you. And I said, once you get that, you feel yourself centered, I want you to move on to your right leg, and I want you to stand on your right leg only. So I gave him sort of center of mass and just standing up on the right leg.
So I love the sidestepping. So if everybody's following here, this is a guy who stays long on the left side on his hip, his lateral hip, and short in the left trunk because of the, you know, hiking the pelvis up and the whole thing, and trying to gain stability way over there. And the right sidestepping takes him completely out of that. He has to actually shorten on the left hip and gluteus medius to push off to take a step right in right side bending, and then he has to control the eccentric piece of it to bring his left foot back in. As he said, you know, so as he'd like to get ready to do the step. So although it's making him stay on his left side, it's working him in the opposite motions than he's used to doing. So there is something for that, even though I know Erica was trying to get him over that right foot, and she did some great things then to start having him think about how he's weight bearing. And that's an easy tune-in thing. Where are you on your feet?
Right.
Can you make a difference? Can you change it? Good. Now, see how you can do when you go ahead and stand on the right foot. So, you know, and then that acceptance of the weight onto the right foot with the left, with the right side stepping is also really good too. So I love it. And then of course the rotations left are perfect.
Right.
For the trunk, you know, to break all that up and bring rotation into the system every time can change the motor recruitment pattern.
Yep. So he said, can I do lunges? I was like, yeah. No, I mean, something I wouldn't have given him, but I'm like, if you want to do some posterior lunges, do it on your right side. I was neither here nor there with that, to be honest. If he wanted to do lunges, that was fine. So that's what I sent him home with. I saw him this week. He's also a lefty, by the way.
He's the left-handed?
Yes.
And he carries his child on the left side. See,
Correct.
It has nothing to do with handwriting and ease of having another extremity available.
Yep.
It's interesting.
Yep. So he came back, and I know I'm a lefty too, so I'm kind of wondering what I'm doing all day. So he came back. I saw him yesterday, actually, and he was doing everything I told him, and he says it's working out well. The first thing he said to me, he says, this is the first thing. He says, I really believe changing my daughter's position on my hip will help a lot. It's the first thing he said to me. I was like, God, if it were only that simple, if everybody was that simple like that. I was like, oh my God.
But the awareness was the piece that he needed.
Totally.
He just, he was like chasing these anatomical tissue structures, to change what was going on with him. Like, it's got to be here. I'm poking to death that poor little TFL. Mm-hmm. And basically what he needed was some strategy changes for his environment so that he could build a different pattern.
Yep.
He needed to move his whatever left screen to the center or wherever he wanted to put it, and he needed to, but he became aware of how much he was staying in one position and probably hooking it up to his symptoms and how he felt. Mm-hmm. And like, wow, if I didn't stand over here like this all the time, maybe it wouldn't hurt so much.
Right. Exactly.
So then he, but that's great.
Yeah,
Love it.
He's pretty clued in now. So that's what he said. And he said, it's working out well. He's getting a sit to stand desk, which I think will help. I'm like, when you stand, just don't stand on your left leg. I don't want to create another problem. He moved one of his screens over to the middle. He goes, it's funny, the screen that I use the most is on my left side. I said, there you go.
Yeah, and it's probably, who knows? Again, that diagonal preference.
Correct.
That all of us have. We all have it. So.
Yep, for sure. And he's like, I'm really focusing on getting my weight on my right leg. I'm like, that's great. And when so I had him stand. So he goes, I did some single leg squats on my right. I was like, oh, how did that work out? He's like, God, 3 sets of 5 just killed me. 5 reps, 3 sets. I was like, there you go. Just goes to show you where the strength hole is when you actually isolate your right side, right? Because he's doing all these double leg weight bearing, Metcon, and not doing a lot of single leg activity, obviously, because that would have come up, I think, these strength holes. So I had him in standing, and he was away on his right leg. I'm like, you got it. So I wanted to get him. I said, I'm trying to how I can verbalize this. I did not want him to go the other way, like completely the opposite extreme. I needed him centered. So, because I don't want to create another issue. So I tried to get him to understand that. So I said, I need to take your shoes off, take all your socks, everything. I need you to feel your feet rooted to the ground, and I need you to center yourself. Not on your right, not on your left. And he was like, oh. And so he got himself back to center. He was literally on his right leg. Okay. I think he took my advice to the extreme, which is okay.
And that's good, because he started to change things, and now it's like, now let's give you some variance all the way through.
Totally. So his bony landmarks, I just checked his PSI, iliac crest, totally minimal at this point. I had him do a wide base of support, completely equalized once again everything. Okay, put the TFL on slack. I was trying to explain that to him, because I said the wide base of support levels you out because it puts a lot of those lateral structures on your hip on slack. They shorten. They're not being taut or tensioned. So, obviously you're not going to walk around that way. But when you do go to the gym and do squats, you're going to have to start with that wide base of support. I basically have watched him squat. I put him back on the rack, and he squatted pretty good. I mean, he was very mindful of where his weight was. So I brought him back into the room, and a couple things, and this was just the only visit I've had sort of treatment-wise with him besides the initial evaluation. I wanted just to see, and in hindsight, this didn't add anything to the picture, but I wanted just to mobilize. I wanted to see if I can get a little bit more hip flexion on his left side. It was just more of a curiosity for me. So I went in to just to mobilize his hip a little bit. I did a little bit of distraction. Didn't really change anything. I didn't expect it to, but I wanted just to see, because his hips are really, really tight. But they're equal. So it's not like the left one is more tight than the other. So then what I had him do is I got him on all fours. And I did a little bit of soft tissue work. Actually, I'm going to backtrack on his posterior hip capsule just to see if I could release some of some of the muscles in the back, some of those deep rotators, a little bit. I didn't spend a lot of time with that. I got him on all fours, and then I said, let's just play with the weight shifting on all fours, and then we're going to sit back. So hands and knees, I had him shift his weight to the right, and then I said, just go try to sit back on your heels when your weight's on your right side. He said, no problem. I said, get back, go back into full, 4-point kneel, shift your weight to the left. Susan, he couldn't even sit back. So I want your thoughts on that, because his hip was so tight. He literally shifted everything to the left, tried to sink back into the heels, could not do it.
I think it's, a couple of things. Probably some structures over time have changed, but I also think probably I would have to say that there are some, that neuromuscular pattern dominance when you get into that folded position. And he didn't have the best hip flexion, right? So very, very hard for him to get down in there without maybe over flexing his lumbar spine or over flexing his thorax. So he couldn't get down enough to sink down. Some of it may have been too with the lack of dorsiflexion under his feet.
Mm-hmm.
especially the right side. So, I don't know if, sticking a
that's right.
like a wedge or a barbell under his heels, just so he has something solid. It's like kind of just something for his heels to sit on as he goes into the squat, to see if he can come on down a little lower to take up whatever the tissue isn't going to lend.
In 4-point neo, you mean, right?
Yeah.
Yep. That's a good idea. Yeah.
So just some again, things that can maybe increase that proprioceptive input is all I'm thinking about. Sometimes you just put something up against the feet, and it can start to change how the body can come back down onto it. It's just a little trick we did in neuro rehab all the time, is we had people who were trying to figure stuff out. Oftentimes, if we gave them input through the foot, different ways of input through the foot, they could pretty much change some of their mass movement patterns a little bit. And that's what it sounds like to me for him, is that he just has some, in his quads and his knees, and just that folding piece for him sounds like it's a challenge.
Yes. It's pretty consistent, squatting, sitting.
Yeah.
So what I did is I actually had him move his knees wider into a wider base of support.
And that works. That's just like with the squat. When you got him to go wide with his feet, he was able to go down a lot easier. So some of that could be, again, some of that's hip. Some of that could be that maybe he's got really retroverted hips too, so he doesn't do well when you get him closer to what we consider neutral alignment. His neutral may be more slew-footed. And somewhere along the line, he corrected that because somebody told him to walk with his feet straight.
Right. I actually think that's a good point.
Yeah, and so he may never have the best hip flexion.
Nope.
With his, in what we consider neutral alignment, he may always do a little bit better with a bit of outward rotation.
Totally.
And that may just be something he needs to do. So he needs to kind of think about that with deadlifts and squats and even lunges.
Yep.
That it's going to be more difficult for him to go straight down, that it's okay to let the knee and the foot maybe go to the side a bit and see how he copes with it, because we got to also pay attention to what can be the structural reasons that these are happening. We just need to balance around structure, for that person. And, being, he's a swimmer, and I mean, the guy is like healthy,
totally.
So just being able to help him change those movement patterns over the structure can be quite helpful, especially if he can gain more hip flexion with a bit of hip abduction or external rotation, or both, a bit of it, to get him more in what would be considered his neutral for his hip, position.
Yes, totally. I agree.
Hip torsion, yeah.
Hip torsion, yeah, I agree. And, when I mobilized the hip, I was like, let me just try. It just took me 5 minutes, and I knew that wasn't going to help, but I wanted just to confirm that hypothesis. And so I also had him do the wide base of support. I moved both of his hips into external rotation. And I said, you're going to play, this is your starting position. I actually gave him that actually as a movement to do. So I said, on your hands and knees, wide base of support, put your heels together, get externally rotated hips, and I want you to shift your weight to the left, and I want you to rock back and see how far you can go. That's what I did from a movement perspective, just to see if he could open up his hip. And then I brought him into the gym, and I just had him basically do, which is interesting. So I had him do, since he's a lefty and I'm a lefty, I can throw pretty well either side. So I said, I want you to step onto that right leg and throw the ball to the right, like one of these little Swiss balls against the what do you call it? On the gym, we've got this sort of like padded wall. So he did a step, throw to the right, step, throw to the right. And I said, just do the left, because I'm curious. And he had like zero. He didn't have a lot of power to his left, which is interesting. I said, that's why your backswing is so good, and your follow through just sucks. So
well, and the power that we get from throwing comes from the lower quarters, so that makes that's interesting.
Yeah, it was, because he I didn't want to reinforce to step to the left and throw, so I just had him do ball throws to the right. I just step to the right, do that, do like 30 to 40.
Was he throwing with his left hand, step
No,
right?
he had the Swiss ball in both hands.
Oh, okay, yeah.
A bigger ball and step and throw.
Yeah, well, that would make sense because he doesn't have the power. Well, he doesn't have the motor control change to have the power from the right leg to throw.
Correct.
So that's important because, he's a lefty. I'm sure he probably would like to throw the ball with his left hand.
Yeah, so I'm wondering then, now that we're talking.
Now that you can have him go out and play catch with somebody or throw balls against a wall with just the left hand and see how he can cope with really getting over that right leg and generating the power from the right lower quarter to give him the better overhead throw.
So, but these were side throws. So, if I have him, so he had the ball in front and he stepped to the right, like a side step to the right and threw. Mm-hmm. And he is pushing off that left side. I am wondering if I could reverse that and have him focus, even though I don't want to reinforce that left leg in that step to the left pattern. I'm wondering if I have him throw to the left and have him push off the right. I'm not sure. Is that worth it to do you think?
I think going both directions is worth it at this point.
Yeah.
Because I think the more variance you get in those patterns, the more richness of movement he's going to be able to tap into.
Yeah.
So I think at this point, just exploring all of those things, I would get him into some like baseball throwing as well on both sides.
Yep.
Just to kind of like have him, the fun activity, if he likes to do that kind of stuff. I don't know if he does or not.
Yeah, he's into it. He's definitely into it. Mm-hmm. So I'll tell you a couple of the things I did and then I'll get your feedback. I just had him do wide base of support squats, very easy with the bar. We did that on the rack. And I basically had my hands behind him. I monitored his center of mass, and he did like 30 squats on the rack. Pretty good. And then we have a sports cord. So I wrapped it around his waist and I had him just do sidestepping down the track against resistance. And that's what I did. So I gave him the all fours exercise, the sit backs, in addition to what he was doing, and just some wide base of support squat. So that's where I am. I've only seen him twice. So in addition to the baseball throwing, is there anything else that you would suggest? Because I'm going to see him next week.
The only other thing that I would suggest is anything that you can do that gets him on his right foot with his left arm up in the air. Okay. Whether you want to do chops or you want to do twists or you want to do whatever. And I would go back and forth both sides, both ways, just to see if you can get those full diagonals going.
Yep.
Does that make sense? Yeah. Yep. So with the right, so if he's going to shift to the right to stand on the right leg, maybe it's time to start putting the left hand up in the air and doing turns on a foot on the ground, to begin to just pull that whole piece in.
What about standing with the right leg in a sort of a stride stance, like a little lunge, right leg in front, left hand above, and doing like a PNF cable across the body?
Any of those things are fine. Wonderful. Yep. Just being able to restore those deeper kinds of diagonal things in there can be, I think, quite helpful for somebody. And especially since does he still swim?
No, not really.
Has he thought about
not in New York City? Say again?
Has he thought about getting back in the pool?
No, he hasn't, because he's 38 now and he swam in college, and no, he wants to work out in the gym. And that's the sense that I get. Yeah.
I don't know. I would probably ask him, I wonder what would happen if you got in the pool.
Okay, I could ask him.
just mainly because it brings in both diagonals.
Yeah.
And it's going to emphasize the posterior chain.
Yeah.
Instead of that quad strategy that he has so much of. But, if he doesn't want to do it, that's cool. There's 1,000 other things he can do.
Yeah, I think with him, and I told him, I said, changing your sitting position at work and changing how you carry your daughter will give you at least a 50% reduction in symptoms, because those are the movement patterns that you do mostly.
Right.
At least. And,
environmental construct variability is great here. Does he have a row machine at the gym?
We, I don't know. I could ask probably, but we do in our gym.
Yeah.
Why?
So, because he could sit on that and he could also pay attention to weight shift. Is he
like an erg rower, right?
Yeah,
Or a seated erg. Yep.
seated rowing.
Yep.
Like if you were going to get in a rowboat,
Yep.
that kind of rower. But he can pay attention to his feet, to his butt, and to how he's leaning, and that can help him drive more through that right foot and right leg. And he can because he's already paying attention to shifting and sitting, where his feet are. This is just another position, but it can be something that can help drive and change some of those patterns a little bit. And he's using both arms.
Yep.
And and he's doing forward and backwards movement of the trunk. So that could be also something, if he really likes the gym, that he could do as a 5-minute warm up.
Yeah.
Or in between sets and reps of lifting, if he wanted to get a little bit more cardio, he could hop on the rower for 2 or 3 minutes, and then go to the next exercise and hop on the rower for a couple of minutes. Something, whatever he wants to do with it. But that would be really good, with the caveat that he pays attention.
Yeah.
So not just falling over onto the left side and just
He'll
going with it, sitting on the left side doing all the work, instead of, the right side being part of it.
It's interesting. I agree 100%. That row is a great idea. I think integrating the arms. So I always tell people that even though they've got like a left hip or a left foot or a right foot or whatever, you need to integrate arm movement in the movement pattern. Squatting, okay, he likes to do squatting, but he does use his arms with the bar. But if you want to get someone to equalize their weight bearing or get them off one side, you want to do those diagonal patterns, because you need to incorporate the arms, because that's life, right? So I would not ignore, just throwing that out there to the audience, I would not ignore the upper body, even though he's not complaining of anything in his upper body. These people they need to use their hands in the movement patterns that bother them. He needs to pick up a weight and squat. He's sitting at his desk. He's on the phone. I think incorporating arm movement in whatever shape or form, depending on their presentation, is really important. So I love those diagonal patterns. That's a great idea. Yep. Cool. I've only seen him twice. So, and there you go. I think these are great ideas. And I think that for him, he definitely will. He's going to want to push himself. And these are the kind of people that just want to be better yesterday type of thing. But these people are willing to work. And if I can get him, because at the end of the day, if he just doesn't, I always say, what do you want to be able to do better? Forget you want to get rid of your pain. I know you want to do that. I don't say it that way, but say, is there anything that you want to be able to do? What's meaningful for you? I want to go to the gym in the morning. Okay. So that's what I focused on. If he didn't want to go to the gym in the morning, I wouldn't really be focused. I would give him things, but they would be different. Oh, I want to be able to stretch. I want flexibility. I wouldn't give him these things. So because he'll be compliant with the thing that means the most to him. And that's that. Anything else? Are we good?
I think we're good. Great.
Good. So
great discussions.
And also, I don't know if anybody has our last, not the last one, the one before, where we had, I told everybody I was going to update on my patient. I think this was 51, maybe, the nerve roots. So you can listen to the episode if you haven't listened to it, but he's doing significantly better. The only main issue we have at this point is I wound him up, and once again, this won't make sense if you haven't listened to the episode, into a full right extension quadrant, lay down, down the leg. I'm getting him into those patterns with throwing. I'm having him throw because he has a nerve root issue on his right shin. He's much better. He's running now. We're progressing running. So I just promised everybody I would update on him. So that's that.
Sounds great.
Thank you, everybody. Enjoy the rest of the summer if you're listening to this live. See you soon.